Today I will talk about pharmacology, labor analgesia. And the main labor analgesics are opioids, nitrous oxide, and epidural analgesia. And you might want to just remember that most anesthetics will pass the placenta. If you give an analgesic in phase 2 of labor, it is likely that the baby will also be affected. So just remember that. Let's talk about opioids first. We have strong opioids. Some examples are morphine, pethidine, fentanyl, remifentanil, buprenorphine, and pethidine. There are many more, so these are just examples. And we also have weak opioids. The most well-known weak opioid is codeine. This figure shows opioid receptors and where they are found, mainly found in the body. They are found in the cortex, in the brainstem, and in the spinal cord. I will just mention what is in Norwegian called a sovedose, which in English translates to sleeping dose. And it's typical to give this at night when you know that the pregnant woman won't give birth during the night, but she needs to sleep. And then you typically will give zopiclone and morphine together. Zopiclone's mechanism of action is that it is a CNS suppressant. It has high affinity for binding sites within the GABA receptor complex. So it enhances the normal transmission of GABA. General indications are transient and short-term sleep difficulties in adults. And of course, an indication is to induce sleep for pregnant women. Typical dosage of zopiclone is 5 milligrams. You can give more, but the typical dose is 5 milligrams. It must be taken shortly before going to bed, and it is given orally. Zopiclone characteristics are there's a fast insertion of effect, about 30 minutes. It shortens sleep time, and it means it shortens the time that the patient will fall asleep, and it extends the duration of the sleep. And it also decreases number of nightly awakenings. Yeah. So we are moving on to morphine. Morphine has a central analgesic effect. Indications. The main indication for giving morphine is strong pain. If you give morphine subcutaneously or intramuscularly, you get an effect after 15 to 30 minutes, and the max analgesic effect after 45 to 90 minutes. If you give it intravenously, the patient will have an immediate effect. And the maximum analgesic effect comes after about 20 minutes. And the duration of the morphine effect is 4 to 5 minutes. 4 to 5 hours. And morphine can also be given orally. There are some cautions when it comes to morphine. It has potential for abuse, and tolerance and dependence can be developed through long-term abuse. One should not use morphine during pregnancy, except during labor, and even then be careful. Especially, it should not be used in the third trimester unless the potential benefit outweighs the potential risk of the fetus. Morphine passes through the placenta and should not be used in the second birth phase and in preterm birth because it may cause neonatal respiratory depression, and resuscitation may be necessary. In the latent phase, you may give Palladium forte, suppository. It's a mixture of codeine and paracetamol. Characteristics for codeine is that it is a morphine derivative with analgesic, antitussive, and some sedative effects. And paracetamol is a painkiller, a weak painkiller. Morphine and codeine taken together gives a synergistic pain-relieving effect. And this combination is often given at a more severe pain than paracetamol alone can control. Indications in this case is to be given in the latent phase, and it should be given as with a dosage in interval of 4 to 6 hours as a suppository. And the half-life for codeine and paracetamol is the same. It is 2 to 4 hours. And when it comes to pregnancy and also breastfeeding, data from pregnant women who has used the drug do not indicate harmful effect on the course of pregnancy or the fetus or the newborn baby. But in cases with long-term treatment of the mother in pregnancy, neonatal abstinence has been seen. And neonatal respiratory depression has been seen with the use of codeine at birth. Pethidine offers a good pain relief for most patients. It won't take all the pain go away, but it will make some of the pain go away. The normal dose is 75 to 100 milligrams intramuscularly. It is short acting in the maternal body. It has a maternal half-life of 3 hours. In the fetus, the half-life is longer, about 18 to 24 hours. It has a metabolite, norpethidine, which has a long half-life in newborns, about 60 hours. And it may lead to seizures in the baby. So we're moving on to nitrous oxide, which is also known as laughing gas. It is sweet in odor and in taste, and it is safe. And it does not affect contractions. But it's not sufficiently potent to provide general anesthesia alone. It is used in the first stage of labor. It is not effective in the second stage. And it blocks NMDA glutamate receptors. So it inhibits excitatory stimuli. Nitrous oxide is given in a mixture with oxygen, and there are varying analgesic results. It is self-administered by the patient, so it is important to give the patient instructions so she can use a correct inhalation technique. And it is also important to remember that there can be a gas leakage. So the team around the patient may get some nitrous oxide inhaled. So we're moving on to epidural analgesia. This is an injection into the epidural space, and the goal is to give pain relief without motor blockage. It is the most effective pain relief in labor, and it can also be used as anesthesia for C-section, and it requires trained personnel. Epidural analgesia is often given as a mix between local analgesics and an opioid. The local anesthetics typically used are lidocaine, chlorprocaine, or bupivacaine. And they are given in higher concentration for C-section, and they also give motor blockage in C-section. Yeah, they are mostly given as a mixture, a local anesthetic and an opioid. For instance, bupivacaine and with fentanyl. So one drug or possibly a mixture of several drugs is deposited in the epidural space outside the dura. And the effect occurs partly by the effect on the nerve roots in the area, and partly because of the drugs diffuse through the dura and into the spinal fluid. And a combination of low doses gives a selective blockage, which is a good analgesia without significant reduction of muscle power and sense of touch. For instance, a local anesthetic, an opioid, and an alpha-2 agonist. So I'll just give some examples of substances that may be used in epidural administration. So for instance, ropivacaine. It is a local anesthetic, and it blocks severe impulses, and it is indicated as for epidural during birth. And the dosage and administration is adaptable to procedure and response. That means that you will, once you are a part of a team, you doing labor, you will be given instructions by the local labor team about how to administrate and how to dose the drug. Yeah. Epidural use of ropivacaine in terms of obstetric anesthesia or analgesia is well documented, and no adverse effects has been observed. So it is safe for the baby. So we're moving on to fentanyl. Fentanyl is an opioid. It gives a morphine-like effect. It binds to opioid receptors in the brain and the spinal cord, and it produces analgesia. And if you give fentanyl as an epidural administration, all body sections below the cervical level are kept pain-free. Yes, moving on to xylocaine, which is a local anesthetic. It can be used as an infiltration, where you spray it in the perineum and the epidural. You can give it as a spray in the perineum, and you can give it as an epidural. Xylocaine has a relatively short impact. It works quickly, and it has a short working time. And also, when it comes to xylocaine, it is adaptable to procedures and response. You will follow your supervisors during birth in the beginning, and then you will learn how they do it at that local hospital. So when you use it as a spray, it is a surface anesthesia, and if you use large doses, it can cause toxic reactions. And there is also a risk of contact allergy. Ephedrine may also be used for epidural administration. Ephedrine increases the release of norepinephrine, and it also has a weak direct agonist effect on alpha and beta receptors. Ephedrine mimics the profile of adrenaline. And it is used in spinal and epidural anesthesia for hypotension. And used during labor, the typical dose is from 10 to 25 milligrams intravenously, and it can be repeated if required. It can also be given intramuscularly, and then you will give 50 milligrams. Side effects are tachycardia, arrhythmia, and hypertension, etc. And when it comes to short-term use in emergency situations, there are insufficient data. So we're moving on to spinal anesthesia. And it can be used for operative procedures such as forceps delivery, C-section, a manual removal of placenta, or trauma to the birth canal if there is a repair to third-degree tear. Spinal anesthesia is performed with a subarachnoid injection, and it is given as a low-dose, short-acting opioid analgesic with or without a local anesthetic. The onset of the effect is about 5 minutes, and it lasts up to 2 hours. General anesthesia can also be used during labor. It is not commonly used, but it can be used. Advantages of general anesthesia is a rapid induction and an optimal control of the airways, but there is a risk of fetal depression, and it also requires an anesthesiologist. And the drugs used are the same drugs as used in the general anesthesia: inhalation anesthetics, relaxants, hypnotics, such as propofol. And some other methods used for pain relief is a pudendal block, paracervical block, and infiltration anesthesia. So this was all the slides I have. If you have questions, you may email me. So, thank you.